I'm making it stream now.
Great.
Okay. I'm making it stream now.
Great.
Oh, okay. I'm making it stream now.
Great.
Oh, shall we get started?
Sounds great.
Hello, everybody. Welcome to our third installment of the BCPH webinar Health-A-THON. Our selection today is entitled Can Compulsory Cultural Competency Transform Health Equity? And this session is actually from our Great Health Debates, this one from spring 2023. And it's led by our host, Fatu Berry, who at the time was pursuing her MPH at New York University. And she led panelists Dr. Christian Bazadi, K. Nikki Forova, Abiba Saluha, and Dr. Ronald Wyatt in a discussion about whether strategies like cross-cultural education actually foster cultural competency in healthcare settings. It was a very lively discussion, and we hope that you enjoy it today. I am showing a slide right here that if you complete watching the entire session today and fill out the evaluation form, we will send you a certificate of completion. If you are unable to join the entirety of today's session or any of the other sessions that we have coming up, because we are going to be continuing the webinar Health-A-THON throughout spring semester, please be sure to visit BCPH Academy at bcphacademy.org. All of these sessions that we're showing are on there, and you can engage in them for certificates of completion. So without further ado, I'm going to start today's webinar.
Thank you, everyone. I wanted to jump in quickly. I'm Dr. Carpenter. I'm one of the co-chief executive officers of the Boston Congress of Public Health. And I just wanted to say a quick word in terms of putting together this particular webinar was very fun and a great success. And just wanted to give a shout out to Fatu, who worked very hard in putting this together. So hope you enjoy.
Yes, yes. Oh, and I'm terribly sorry, Dr. Carpenter. I did not mean to not introduce you. Blame it on the nerves. So here we go.
Public Health's four-part miniseries, The Great Health Debates. Boston Congress of Public Health is a 501c3 nonprofit organization whose mission and vision is to democratize public health through the lens of social justice and to transcend the traditional boundaries of academia and medicine. BCPH does this by supporting leaders, researchers, and advocates who are committed to social justice, health equity, and evidence-based public health thought. As the country becomes exponentially diverse and interconnected, how do we continue to effectively reduce disparities, and what does this look like? I'm your host, Fatu Berry, a current MPH candidate at NYU and fellow at Boston Congress of Public Health. I'm particularly passionate about global health, health equity, and health disparities. With this season being the promise and peril of cultural competency in healthcare, we will be diving into topics surrounding cultural competency, intersectionality, and responsiveness. This series will highlight the perspectives of health providers, professionals, advocates, professors, researchers, students, patients, and their encounters and experiences regarding health disparities, literacy, and equity. Intervention strategies such as cross-cultural education are used by hospitals and clinics nationwide. However, their overall effectiveness is frequently contested. What other implementation efforts can improve the quality of care of patients and individuals with many overlapping and intersectional identities? Allow me to introduce our panelists for episode 4. First, we have Dr. Kristen Bezzotti. Dr. Kristen Bezzotti is a board-certified anesthesiologist and founder of IICFIRM, a learning and development company focused on diversity, equity, and inclusion training programs. She has designed, developed, and implemented training programs for major healthcare systems, medical schools, hospitals, and Fortune 500 organizations. Next, we have Kay Nikiforova. Kay is the head of clinical and research at Violet, which is the first health equity platform standardizing, providing clinical benchmarking, education, care, and more. They are passionate about leveraging technology and advocacy to create more of an equitable healthcare system. Next, we have Abiba Salahu. Abiba Salahu is an incoming resident physician in the Department of Psychiatry at Yale University. She is also a member of the National Gold Humanism Honor Society. She's passionate about community, organization, anti-racism, and restorative social justice work. She also serves as a mentor for marginalized students. And lastly, we have Dr. Ronald Wyatt. Dr. Ronald Wyatt is a healthcare consultant with specific focus on patient safety and quality improvement. He's nationally recognized as an equity champion, and he is also a senior fellow at IHI. Hi, panelists, and welcome. I'm very excited to have this discussion with such an esteemed group today. Let's dive right in. Abiba, I'd like to come to you first. What are methods of cultural competency training that exist today?
Yeah, thank you so much. So as a current fourth-year medical student who's passionate about social justice work as well as health equity, cultural competence is definitely something that I've thought a lot about throughout my 4 years of medical school. At my school, I led efforts to create a call to action preclinical anti-racism initiative, which urged our school to enhance our education to include teachings about diverse patient populations and how we can be more culturally competent future physicians. And in 2009, the Minnesota Department of Health Division reported that adverse patient events are often traced back to communication discrepancies. And they also noted that when healthcare providers and patients come from different cultures, there's often a greater potential for miscommunication. And I think that a lot of current cultural competence training focuses on using materials such as modules, videos, or required readings, and video presentations to help healthcare professionals and students like myself learn how to effectively communicate with and interact with patients from different diverse backgrounds. And as a medical student, my classmates and I in the class of 2020 did a lot of our preclinical curriculum mostly online. And I think a lot of us suffered from Zoom fatigue. And by the end of the second year, we were just pretty much clicking through modules for the purpose of getting them done without actually understanding the deeper meaning and digesting the objectives of the modules that we were required to do. And my program, like other programs, really focused on interpersonal communication. However, a lot of research has shown that just focusing on interpersonal communication methods can leave out larger questions of systemic bias unaddressed. And so that's why I think that it's also really important to incorporate structural competency within cultural competency trainings, because I think structural competency starts to address issues of systemic racism and how we can actually implement action to address these issues. So thank you so much.
Do other panelists have thoughts on what methods of cultural competence trainings exist today? Dr. Bazzotti, I'd love to hear your perspective as a certified anesthesiologist.
Yes, so cultural competency training, it really has evolved quite a bit. So when I was in medical school, I graduated in 2009, what we were being taught in terms of cultural competency was really about identifying and understanding the differences between patients and how that would affect clinical care. So one thing that I remember very clearly was being taught that, this group of patients from this demographic, that they may not actually be in more pain, but they tend to express their pain differently than folks from other communities. Now, this is backed up by studies. This is, you can find NIH studies that are around this. It's very well documented, and this is what we were taught. And so as an anesthesiologist, the way that this gets interpreted in clinical practice is that we end up guessing. We think that we can identify what group that this person in front of us is from, this patient in the recovery room after anesthesia. So we're guessing what demographic we think they're from. And then if they're in pain, we're guessing that, they might not actually really be in pain because this community expresses their pain differently. This is really a very highly problematic approach to cultural competency training. I think they're, trying to evolve it at this point, but I think the kind of bottom line with training and why some places are kind of moving away from cultural competency is because there is no competency that we can reach in someone else's identity or lived experience. And I think that there are other ways that we could move forward.
Which brings me to my next question. How effective are these trainings? Kay, I'd love to hear your perspective on this question.
Absolutely. And as the two of you were talking, I was just thinking about, what does it currently look like? I think kind of going to the history and also the current state of cultural competence education, oftentimes it's really focused on trust, communication, I think sometimes considered more soft skills, which I don't think cultural competence really is. And even if there's knowledge that's being shared, cultural knowledge, it's really kind of fact-based and oftentimes very deficit-based, really from the perspective of bringing, kind of a community's trauma to the forefront to show to clinicians. And one of the things that I really see that's missing is also the clinical skill element. Kind of referencing that piece of having to guess. I think oftentimes it's not included as part of cultural competence training, the actual practice of how to care for communities, whether that's mental health or medical. And I think on top of that, one of the other things that comes to mind, the most effective, kind of from the research, some of the most effective cultural competence trainings, if they are effective, really focus on self-efficacy and not only giving that knowledge, not only giving some of those skills, but also empowering clinicians on how to actually put that into practice and have examples of that and have role models of people putting that into their clinical care. I think that that's one of the places where cultural competence training at the moment is seemingly falling short, because it's a lot of facts and not a lot of ways of like, this is how you actually put this into practice.
If I were to play devil's advocate and say, cultural competence trainings are super effective and they work perfectly fine, what would you respond to something like that? Dr. Wyatt?
No, it doesn't. And I think I will reiterate everything that has already been said about this. It is not a check the box exercise. It is not we must meet this requirement this year because it's a part of the requirement of our healthcare system. It goes way deeper than that. And Dr. Bazzotti has already talked about it. Kay talked about it. We have to begin to better understand with humility the social, the economic, and the political lives of people that come in seeking care. Part of cultural competency then is to be able to listen with humility, not to check a box. So that requires systematic commitment to what we're calling cultural competency. So until we get to that point, as the first speaker talked about, beyond a check the box exercise, where all too often people memorize the answers from last year so they can skip to the end of the test, for example. So it goes way beyond those types of things. And my perspective is it goes back to a systems leadership's commitment to these efforts. Patient safety officer at the Joint Commission, to the point that was made, one of the biggest root causes of failure and harm was communication failures. And a lot of that has to do with not a commitment to a person's social, economic, and political self. The historical trauma that people bring in to a clinical setting. So I see this as a clinical competency that needs to be measured, and there has to be accountability built around it beyond the typical off-the-shelf, check-the-box type of exercise.
And I'd like to circle back to Abiba. Abiba, you mentioned the modules and the trainings. Kay also mentioned it, and Dr. Bazzotti and Dr. Wyatt as well. What are alternative potential barriers besides just clicking through the modules that exist within policies surrounding these cultural humility or cultural competence trainings?
Yeah, so I know that within medical students in particular, a lot of hesitancy and pushback surrounding cultural competency trainings is the fact that making them mandatory automatically creates resistance among students and is seen as another assignment that they have to do when they already have like a million exams that they're studying for and things like that. And I think one of the biggest barriers from my perspective is the passive nature in which a lot of these modules and trainings are often delivered. I think that they're definitely very effective based on the research that I've done and the literature that I've seen, that they are effective in increasing awareness about healthcare disparities. But I think a lot of studies have shown that the way that they can be very effective is by actually implementing hands-on experiences where learners are going into the community and interacting with the people that they're learning about rather than it being this distant learning experience. So I think the passive nature is definitely a barrier, but that can be addressed by implementing more community-based learning.
Yeah, which brings me to my next question. Dr. Bazzotti, can you speak of the trends against implicit bias trainings besides the resistance? And what does this mean for healthcare? What are the potential implications?
Right, yes. So if I can just touch a little bit on what Abiba was just discussing, this point about whether trainings are mandatory or whether they're not mandatory is something that is going to keep coming up whenever we're talking about anything that is diversity and inclusion related. And there are reasons that people push back against this being mandatory. And we don't need to be mouthpieces for that. For those of us that really care about this, we would never ask or question if, physiology or anatomy should be mandatory or not mandatory. Healthcare disparities exist. And something that we heard is that the trainings are very good for raising awareness about healthcare disparities, but when we are working with patients, it is not just enough for us to be aware about healthcare disparities.
And thank you for watching.
There is plenty
My
of
name is
data
Rachel
and
Barnett
research
with
about
Gentle
healthcare
Frog.
disparities, and
I'm here
yet
to create
and still,
videos for you
they
to help you
persist. And in
understand.
fact, the data coming out from COVID in 2020, they got so much worse for many communities, and it's not getting better. And this is coming back to training and what the role of training is. Are we looking just for awareness? Are we looking for skill development? Are we looking for processes that are going to hold people accountable? When we get into actual clinical environment, we are not roaming out in the community. We have patients that are right in front of us. And the vast majority of physicians who are taking care of patients are very uncomfortable to engage in equity conversations. That has to be addressed, because when people are bringing these things up, we need to be able to engage in those conversations, and there's reasons that we don't. Now, in terms of implicit bias, as someone who designs DEI training, there has been a massive movement since 2020 at an organizational level. Organizations have set new policies in place after the murder of George Floyd. The policies that were written were very focused on anti-racism. They were inspired by BLM, which is an activist level movement. And organizations, when they put these strategies in place, the only training that they really had to back it up were either cultural competency or implicit bias. And those two are not the tools and the mechanisms that are going to help the everyday person and their organization deliver on this level of anti-racist and really advanced care. And so we have to consider what we would call the equity fluency of the individuals inside of the organizations. A lot of organizations are moving past implicit bias training. It is a start, it is a beginning, it is a first step. But if we want folks to get to a place where we can hold them accountable, we really have to train them in skills and processes in order to really create those cultures of equity within organizations.
I have a question that I actually wanted to pose, because I've been sitting with this myself for a while. As you're talking about that, and the fact that movement away from implicit bias training are just these sort of standard out of the box, this is what it is, cultural competence checkbox. It's very interesting to see that at the same time, this is also some of the first times we're more on a regulatory, like governmental level. We're having class come out, like different states are enacting standards of, yes, like your clinicians in the state need this for licensure. Colorado came out with regulation of actually having training, and then Michigan, I think, also actually, interestingly enough, defaulted to implicit bias training as their cultural competence piece. And so there's this kind of balance of like, it's on my end, it's like, I think it's really important for there to be some regulation around it. And then simultaneously, it's kind of moving in a direction that we're already moving away from in this space. And there's no standardization, and there's no definition, and there's no specific outcomes for all of these trainings. So I'm kind of curious, like, as the field itself is moving away from this, it seems like the government is starting to kind of just get into the space. Does anybody have any thoughts on that?
Yeah, it's Ram. If I can react to that, and it's unfortunate that we have to come to that part of the conversation. And you're right, Colorado, California are now requiring at a minimum implicit bias training as a part of licensure and renewal of license. And it's unfortunate and sad in a way that we have to come to that. But I would say that requirement is, if anything, remedial. So it's, again, unfortunate that it now moves to accreditation standards and conditions of participation through CMS and other payers who are now beginning to require this basic level of training. So that is where we are. And because of payers and the Joint Commission and the big payer CMS, but this also goes now to the Veterans Administration, to the military health system, that are saying we must do more than this. And it's back to Kristen's point that implicit bias training, to me, is remedial training. It should be required. But now let's look beyond that. If I put on my patient safety hat for a minute, we're talking about inequity as an unsafe condition. It hurts people. And let's be frank about it. People end up dying because of the root causes of these things that we sometimes shy away from. And we get the pushback, like the pushback against what's called wokeism now. And in some states now, there's legislation being introduced to criminalize DEI training. There's a couple of states like that. 8 states are suing CMS to say, you can't tell us to have anti-racism training. So that's the environment that we're in, and why we must persist in this work. So if we have to have accreditation standards and regulatory standards, then I say so be it, because the same kind of, I call them conspiracies of complacency, have gotten away with this for too long. And the data, as Kristen says, tells us that people continue to be hurt, harmed, and, let's face it, killed. And I will say that in this country, racism is a root cause for preventable death. So we need to be reactive and prospective about these approaches and make them more robust and make them sustainable. The same applies to sexual orientation and gender identity. The same applies to ableism. The same applies to sizeism, that all of these things now we have to put in place patient safety language, forcing functions and accountabilities. And that accountability that's built into the CMS regulations and the Joint Commission standards is that leadership must be committed and demonstrate that commitment to creating cultures of equity. And if you don't, then there should be consequences. And in many states already now, and with some payers, the consequences is we're not going to pay you if you continue to report on disparities and do nothing about them. I'll stop there.
If I could just add one thing to that, I was doing research for a course I'm writing for another client, and I was reading a paper today, and they were talking about cultural competency in the paper. And this is a top 10 medical school, a very competitive program. And this was their definition of the point of training their medical students in cultural competency. They want to identify how diverse expectations from the diverse patients that they serve lead to perceptions of unprofessional conduct, both real and imagined. I mean, this is why I'm not a fan of cultural competency. We have to understand that there is an agenda to keep this DEI training very watered down. There's an agenda to keep it, it's just unconscious. It's no bad intent. Nobody was thinking about anything. We don't want to be honest. This is not a reason or how we should be training medical students. This is basically saying these people over here are different from us. And because they're different from us, they're perceiving us in a different way, which is accurate. They are perceiving us in a different way, but what they're perceiving may be imagined. It's not actually unprofessional. They're just imagining it that way. That puts us at the center of the universe and the world. And it means that we persist in the same reasons that cause racism and every other ism and issue. It's this idea of centering a dominant culture and that culture maintaining power and everyone else expected to adjust. The watered down DEI training is an agenda. People want that. And we have to keep pushing forward and being honest with people, because what we don't want to say is that actually, as physicians in a healthcare environment, we exist in that environment in an extreme power advantage. And because we are in that power advantage, like anyone who's in a power advantage, we don't have to listen if we don't want to. And nobody's going to hold us accountable to that. And so there's communication problems because we're in a power advantage. Medical students are highly disincentivized to speak up to their attending physicians. They don't do it. Residents are in $300,000, $400,000, $500,000 worth of debt, and they are highly disincentivized to speak up about anything that they see. There is no reporting culture. There's nobody to hold anyone accountable. When we have folks like Dr. Wyatt that are pushing the policies at the highest levels with the Joint Commission and the IHI and everyone else, we have people pushing back because it's intentional. And that's what I think we need to be honest about. And Dr. Wyatt can speak much more than me about policies and the kind of pushback that we get from this.
Accountability. How do we make people, how do we make clinicians accountable? How do we hold them accountable? And what do we do to measure this?
Right. Well, Dr. Wyatt is, the expert in that. I won't even try, but I'll just say from my perspective, what we do is that we measure the equity fluency of individuals. So the organization is going to have its own DEI maturity, and there are scales from McKinsey and Deloitte and all the big four that you can use to look at the organization's DEI maturity. But we actually want to know on a training level where the individual people are at. When we are looking at basic equity fluency skills, I don't think it's important that you have a very in-depth historical context of everything that's ever happened to the, fill in the blank community, the LGBTQ community, the Black community, women, anyone. What I think is more important is that you have the foundational equity skills to engage in equity work. Are you comfortable engaging in an equity conversation? Do you understand how to correct if you've made a mistake? What kind of training have you had before? And what is your mindset and mentality towards equity work? What we have found is that people who have a certain kind of mindset, who want to be engaged in equity work, that they actually do much better in training. And these folks that are just pushing back, don't make it required, I don't want to do it, those people don't really benefit from training that much. I mean, it's hard to like change their attitudes. And so one thing that we need to measure are the capabilities of people in terms of doing equity work. And that should be something that is looked at every level of admission into medical school, residency, and so on. We need to bring more people in that actually wish to engage in this work.
Right. Yeah. So I'll add a couple of things to that. One, I'm involved with the Accreditation Council for Graduate Medical Education on something called Equity Matters Collaborative, where we're designing interventions for trainees to understand inequities and how inequities can be measured in a system. Several big payers now have given their payment data to big systems in multiple states, saying, we've already given you your disparity data. We know that you have have disparities. And one payer has said to their systems in the state that the aim and the goal is zero inequity, and we're going to measure you on it, and we're going to pay you on it. If we come back now to CMS, if we look inside what is called value-based purchasing, you have those domains. One is patient safety, and you can look inside patient safety and say, okay, what are your hospital-acquired infection rates stratified by race, ethnicity, and language? What are your clinical outcomes that are stratified by race, ethnicity, and language? What is your patient engagement scores, or what CMS calls people and community engagement? And if you stratify those now required by race, ethnicity, and language, what is that telling you about your system and how it's responding to the needs of people that are Black and brown or are identified based on some other gender identity? What is your effectiveness and efficiency? An example there is if you stratify readmissions rates by race, ethnicity, and language, it's going to tell you a story. So then this is what I say to the system. What is your history on these topics, disparity and inequity? We cannot be ahistorical about the harm we've already caused historically. The next thing I ask is what's the populations based on the data I just described, one of which is your mortality rate, stratified by race, ethnicity, and language, sexual orientation, gender identity. What is the mortality rate? That's going to tell you something about the clinical outcomes in your system. What is your readmissions rate for Black and brown people that are preventable? How are you treating patients who come in with sickle cell crisis, for example, and what are the outcomes from that? Those are some of the things. The next one in the medical staff arena is that, back to Kristen's point, when people report some type of racist event, incident, or whatever it is they see, have enough psychological safety in your system that it can be reported. And once it's reported, that it is acted on through your system's medical staff office or nursing staff office in an accountable way, and that in some sort of way, you provide that feedback out. The last one, and I'll stop, is that you should have around inequities and disparity some type of standardized performance improvement methodology. Whatever that is. IHI, we use Model for Improvement. It could be DMAIC, it could be Lean Six Sigma and change management, but have one and say strategically a part of our performance improvement plan is that we measure inequities, that we measure disparities as a patient safety, as a quality of care issue. So as we say, there is no quality and safety without equity. There is no equity without patient safety and quality, all of which can be measured. At the end of the day, leadership has to be held accountable. Leadership has to message, we will not have inequity here. To a point earlier from Abiba, then simulate this. Remove, as Kristen was alluding to, the moral distress of what this causes inside of the system for medical students and trainees. So message that in this place, our goal is zero inequity, and we will not give up. We will not give in. We will persist, and we will hold people accountable. The next thing is that when leadership looks at who is going to assist with this, and they look around at consultants, I always say to them, vet your consultants and make sure you're not just bringing in profiteers. You bring in people that are going to build in methods, mechanisms, tools, and approaches that can sustain this work over time. I'll stop there.
I wanted to jump in. I'm just like, I just want this conversation to keep going because this is what I think about every single day. And I think these are kind of the questions to grapple with. I can jump in a little bit with the idea of measurement. The first thing that I'll say kind of as an aside is any single time I do any sort of claims analysis work, disparities emerge. Oftentimes disparities emerge even when you're not looking for them. So it's like, it's so close, it's so obvious. And if people aren't seeing that within their health systems, they're not looking for it, they're not willing to acknowledge it. So I just want to put that in, like it will naturally emerge. And the other thing that I'll say is, actually the work that I'm currently doing, and this is more in the health tech space, but I'll tell a very, very quick story. A number of years ago, the founder of Violet and I were working for a tech-enabled health insurance company. It was kind of like the earlier days of health tech startups. And in that, a consistent request that we had from queer patients, from Black and brown patients, were clinicians that would be able to see them safely, treat them appropriately with competence, if we want to use that term. And so we went about trying to find that, the two of us really, like, is there some sort of certification program? Is there some sort of stamp of approval? And there are a couple of things here and there. But overall, we weren't able to find anything that said, yes, this clinician has been vetted, this clinician has gone through this training, has had this experience. And so I think that's part of the reason why it emerged, this need, because a lot of these sort of standards right now or accreditation is really top down. A lot of it is self-attested. An organization does their own assessment of themselves. And so one of the things that came about is really this need from like a bottom up to really know where each clinician is at in terms of their competence. And I will say cultural competence is a term very, very, we don't have a definition for it. It's been very misused, but I'll use that for this particular term. We really realized that we needed to know where every single clinician was at in terms of their competence in treating different communities. And so in that, we started thinking about creating a framework. Part of that is starting to see cultural competence less as like, this is the outcome and more of an umbrella. Coming up with the idea of work experience, education, lived experience, self-efficacy, communities of interest, sensitivity and awareness, and really getting to this place where while we do need to hold individual clinicians accountable, it really does build up to the organization. To what extent are organizations willing to see, who it is that they're employing, the level that they're at? Are they willing to skill them? Are they willing to give money for them to do trainings and kind of build that way up? And so that's a lot of what we're thinking about right now. Even how do we use this sort of mechanism to care out people? Because at the end of the day, a lot of the questionnaires right now for cultural competence is really self-attestation. A lot of it saying, I think I'm doing well. And there's a lot of bias involved in that, especially social desirability. And so how do we kind of standardize that in a way, both kind of at the clinician level, at the organizational level, and more so at the regulatory level?
I really agree with everything that's been said thus far. And I wanted to quickly touch on a point that Dr. Bezadi mentioned, and that's this concept or issue of those within the dominant culture just centering themselves in the convo rather than doing a deeper understanding of those that are different than them in order to be actually or strive to be culturally competent. And one thing that I've noticed within these cultural competency trainings as a medical student is that we never really go below the surface. We just pretty much name the inequities that exist without actually thinking about why they exist and how we can actually address them and challenge them. And I think in a way, students are taught that certain groups such as Black patients will just always have unfortunate problems associated with them as if it's an innate part of their being rather than the racism that they're subjected to. And I think the hidden curriculum of medicine that Dr. Bezadi was talking about really serves to silence medical students and other trainees. We're often urged to be advocates for our patients and to speak up. But the advocacy really only goes so far if we're afraid to call out racism within the clinical setting. And I think this is an issue that myself as a Black medical student and the handful of other Black medical students in my school have really struggled with over the years. And lastly, I think it's really important for medical students and those in power, those in power within the healthcare system, such as attendings and residents, are able to have an honest conversation and unfiltered conversation about these issues. And for our like white residents or white attendings to be comfortable with being uncomfortable in some of these conversations. And in addition, I think within the trainings, it's really important to look to the minority groups as experts and to hear from them within the trainings, rather than just having the same group of people within the medical system creating these trainings from an outside looking in perspective. I think that it's really important that we actually hear directly from the communities that we're learning about within these modules. And then lastly, I think while it is important to give the people who are interested in this work the platform to do the work, we also really need to be wary about minority tax and just dumping the burden on underrepresented or marginalized groups. As a Black medical student, I think there's often a lot of pressure to be the one to lead the DEI conversations or to speak up and lecture, and that can definitely be really draining. And I imagine that minority attendings and residents are also faced with that same burden. So I think it's really important that all clinicians are taking this sense of responsibility rather than just making it the job of the other marginalized people within the system.
Yes, Ron, again. So thank you for that, Abiba, because it's so accurate. And I'm going to go back to something that Kay kind of hit on, and I'm not going to bury my lead. CMS is now regulating that systems must have an anti-racism plan. So years ago, I visited with a person, Dr. Don Irwin, who is a white internist, spent his entire life in New Orleans, Louisiana. I'm sure he doesn't mind me sharing this. Years ago, we were at a big health systems first equity conference. And Don said something about cultural competency that I'll never forget. He said this to the executive level leaders and the board members at that meeting in New Orleans. I quote, "All cultural competency does inside of a system is to make it a more culturally competent racist system. It is a system. It disadvantages one population. It advantages another population based on nothing more than what we call race. So we need to then enforce the necessity of anti-racism plans. It is built into the CMS language. It is explicit, so that now systems must commit explicitly to address an anti-racism inside of a system, understanding how it operates. A part of that is understanding if resources are being allocated on a race-based basis. And we saw some of that during and after COVID, and where systems knew that resources were not allocated equitably before COVID. So it shouldn't have been a shock and a surprise after COVID and during COVID that we began to see these things that already existed in patient safety language. They were pre-existing conditions based on a system that is perfectly designed.
I think we lost volume, Cersei.
Something about that as well. We saw the CDC released their report about maternal morbidity and mortality recently over the last couple of years. And that we already knew that there were a lot of disparities there. We already knew that it was very dangerous for Black mothers to be going into the hospital having babies. And it really shouldn't be that way. There's no real reason why there should be so many more cases of morbidity and mortality in this one community, other than the fact that the standard of care is not being applied across the board. And as we saw from this data that was released, it got much worse during COVID in 2020. All of us that are practicing, I'm 10 years out, we were all trained in cultural competency. We have to take these implicit bias tests all the time. It doesn't do anything. It really doesn't do anything. We need to be more honest. The way that this is going to get addressed are some of the things that Ron is talking about. We need the accrediting bodies. We need the ACGME, we need the Joint Commission, we need the NCQA to come down with some teeth on accountability for the organizations. They're not doing it on their own. And honestly, if they would just listen to the folks inside of the organization, the medical students, the residents, they see everything. They will tell them exactly what is wrong and going on at a patient and clinical care, but they're not going to say anything. They're highly disincentivized to speak up and be honest about what is going on. What I have found in training in terms of measurement is that we are getting more organizations that are more serious because of these initiatives that are coming down about the outcomes that they're looking to have an impact on with training. And so we have moved from this awareness-based training, which is like, okay, that's nice. Give a college student awareness-based training. But if you're going to be seeing patients, we need to give you skill-based training. And then we need to have the accountability in place as well. We don't go into a hospital and say, you know what, we know that we can decrease the incidence of bloodstream infections from central lines by following this process. We have data on that, but whether or not you do that, we're just going to train you on the awareness of it and let you make the decision. That's not what happens. There are stops and accountability. When you are seeing patients, you have to document that you did all of these things. And if you don't do them, they will not credential you at that hospital. We need that level of accountability, and it's coming down now, but it's going to take some time to get people caught up, because we have been playing these games where we're getting very good data from the researchers and we're not getting good action from the hospitals. One example that I had a client recently, diversity scorecard came down for all of their hiring managers as a result of their DEI initiatives. And the training that we were coming to do was specifically about hiring to improve the diversity scorecard numbers. We had a direct outcome that we could measure, and the training was much more effective for that reason, because we were training them in a process. We weren't training them to just be more aware and feel good about yourself that you're more aware. In our field, people die. Like, we need to be careful and we need to take this seriously. As Dr. Wyatt said, this is not a money-making scheme. These are patients' lives that are in our hands.
Right. And from a patient safety perspective, again, education and training are the weakest corrective actions, the weakest. So what Kristen's describing is more forcing functions and fail safes. Make it a part of credentialing. Make it a part of the true competency for all clinicians inside of a system. That is where we need to go with this. And I'll just give an example. Just in the last year, 2 senior obstetricians contacted me asking for help with root cause analysis involving an African-American mother who died during pregnancy, died during delivery, and from 2 different academic institutions. And in both cases, they came back and said, we know that the root cause of the death of these 2 Black mothers is racism in our system and how it operates. In both cases, those physicians, Black obstetricians, came back to me and said, our root cause analysis process has been shut down by leadership. We cannot even perform the root cause analysis. So in situations like that, then that is where the regulatory organizations, accreditation entities have to step in. That's where the medical staff affairs have to step in and apply medical staff principles that have been described by CMS and the Joint Commission on whether or not a person can retain their credentials and privileges inside an organization where it operates like this.
And before we wrap up, panelists, I want to pose this phrase to you and want to know how you would respond to this. There may be nothing more dangerous than good intentions. What do you think about this phrase?
Well, everybody doesn't have good intentions, and we need to stop assuming that people do. So that's the first thing. A lot of people are very blatantly discriminatory, blatantly biased, if we want to use a stronger word, blatantly sexist, racist, homophobic, ableist, choose it. And so it is not enough for us to just be good people, and it's not enough for us to simply, lend our support to, the movements. We really have to have skills that we can utilize and deploy in the clinical settings. Where training is going, it's moving in this direction, but ultimately where training needs to be is that your training needs to be directly linked to the outcome that we care about. If we want to reduce morbidity and mortality in the maternal unit, then if your training is not affecting that, it's not working. That's the skill that we need to give people. And that is not about good intention. It's about being held accountable and not being able to opt out of things that are critical for patient care. We do not get to opt out of things in a clinical practice in a hospital setting, and this should be on the same level.
Right. And inequities cause people and populations to be disposable and sacrificial. So if I go back to the letter from Birmingham jail by Martin Luther King Jr., when he, in essence, said, it is the inaction of so-called good people that persist in doing harm. So I'll answer it this way. For good people to not act in the face of the root causes of inequity is in and of itself a violent act. Inaction is a violent act.
Yeah, I agree with what's been said thus far. I think the concept of good intentions really serves as like a safety net or safety blanket for people to get away with doing the bare minimum and feeling good about themselves. And it's really like a pat on the back. In addition to that, I think that it's really important that we move further from just, having good intentions and thinking about what we're actually doing and what action is associated with those intentions, and really challenge people to go a bit further than just doing reading or attending a workshop. And I think this concept of good intentions also serves as another way to further silence trainees, especially medical students, and discredit a lot of the bias and racism that they experience throughout their trainees. Oftentimes, I've personally have witnessed if someone complains about an issue or tries to advocate in regards to like a racist event that happened, it's often, the response is often, well, oh, this person, their intentions were good, they're not inherently racist, and the conversation is kind of just shut down, rather than actually challenging the person to think about their actions and the consequences that it had on other people.
I can add as
Would any other panelists?
Yeah, I can add as well. I think that's why sometimes I get so if we have explicit bias. The reason why implicit bias trainings for me sometimes are so kind of tough is because there's explicit bias, there's explicit racism, there's anti-trans healthcare laws being put into place literally, or being introduced every single day. These things aren't silent, they're not quiet. And yet sometimes I'm faced with feedback that I'm so confused about. There was one response after a training that we did. While I cognitively understood that there were differences and disparities, it has been difficult to acknowledge that it's still this bad for people in 2022. And I'm curious why, because it's clear, it's out there. I've had white clinical leads say that they're having difficulty talking about racism, that they're having difficulty saying the word Black. Why? Why are these things still not standard? Why are these things still not the care that we need? And I think it's that it doesn't matter about good intentions. We need to have better care, and better care is more equitable care.
And before we say goodbye to our panelists, I'd like to just give a couple key takeaways. So cultural competency training has many existent barriers, as you've heard. In order for it to even be considered as transformative when it comes to health equity, change needs to happen. Organizations need to be transparent, hold themselves accountable, as well as individuals within the system. This issue also calls on accrediting bodies to listen to those who are working within these systems. And these hard conversations need to be had. Abiba mentioned being comfortable with being uncomfortable. But nevertheless, thank you so much to our panelists for this wonderful, fruitful discussion. I really enjoyed it. And thank you for all the audiences for tuning into all the episodes of The Great Health Debates. It's been a pleasure hosting you. And I'll say bye now.
Thank you.
Thank you all so much. This was
Thank you all for attending today's webinar. We were happy to see the turnout. And we
Hello,
will
everyone. Thanks so much for joining us for the third webinar in our series, heading out for the new year with our webinar Health-A-THON. So join us for tomorrow's selection at the same time, same place. And if you haven't signed up, go to bcph.org and get signed up. And if you were able to watch today's webinar, please be sure to complete the evaluation, which has been sent to you if you signed in, and we can get you a certificate of completion. All of these webinars are on BCPH Academy. Dr. Carpenter, did you have anything you wanted to share before we end today's session?
Thanks again, everyone. See you next time.
So with that, thank you. Oh, sorry about that.